Um, Today's presenters, as I said, are Mike Barry and Peter Cleary. Do you two want to introduce yourselves?
Go for it, Peter.
Okay, I can do that. Hi, my name's Peter Cleary. I use he, him, and his pronouns. I work with Project Neon, which is a harm reduction program here in Seattle. It's been doing harm reduction for 30 plus years, and that's it.
Hi, thank you for having me, Allison and ADAI. Mike Barry, he, him, recent graduate of the Epidemiology PhD program at UW, longtime employee of Public Health, Seattle King County. I've worked in community-based organizations in governmental public health for many years, as well as research. And now I am based in San Francisco, where I oversee research and evaluation at the San Francisco AIDS Foundation. So very happy to be back in a community-based setting and looking forward to sharing some results from my dissertation work at UW.
And that's all for intros. I'm just Allison at UW-ADI. Maybe you've seen me on webinars before, but if you have any questions about Focus on Meth, let me know. But otherwise, let's dive right in. I think Mike has some really great slides and Peter has some really great background and information.
Great. Thanks so much, Allison. And thank you, Peter, also for being here. Peter was part of my research team, so this is really fun to get to present together. Today I'm presenting work, again, from my dissertation research, which I'm not going to read this title to you. It's way too long, but essentially this was a community-based, community co-led series of studies that were designed to understand sort of the diversity of meth use experiences among both men who have sex with men, as well as trans and other gender expansive people. And really, the idea was that, we have a lot of good research on meth use kind of broadly, but most of that is cross-sectional. And we wanted to kind of get some richer information with qualitative research and also ask some very specific questions, which I'll get into shortly here. So before I start, important terms you'll see throughout my presentation. Cisgender men, this just refers to men assigned male sex at birth. Transgender people is the umbrella term for anybody who is not cisgender. I suspect this is familiar to most of you, but this includes but is not limited to trans women, trans men, non-binary people, and other people who identify not as cisgender. And you'll see this CMTSM throughout my slideshow. This is a collective term for cis men and trans people who have sex with males. Um, Epidemiologists, we love to make up letters like this, but this is important. It's important to be specific here because this is really where HIV and meth intersect globally as really a syndemic is in this population. And it's very important to not forget that there are trans people who are at the center here along with cis men. You'll see STUD, this is stimulant use disorder. We used roughly the assist definition of that throughout our research. And then you'll also see this MRAO. This is meth-related adverse outcomes. This was a community-based project, and we worked very closely with our community partners to think about what stimulant use disorder means, what meth-related adverse outcomes are, how they're different, and I kind of talk about them together. Really, just the goal of this was to think about experiences that might not fit into a clinical diagnosis, but still are significant of meth's potential harms to individuals who have used it. So very quickly, I'll go through this background and motivation. Meth is this very, very strong drug with great addictive potential. In the past 10 years or so, the general population prevalence of last year use or 1 year period prevalence of use has about doubled from about 1 in 200 people to close to 1% of the population has used meth in the last year. Meth is disproportionately frequently used in our study population, and important health sequelae of meth include cardiovascular conditions, especially with ongoing long-term use, organ damage, psychosis, and cognitive decline that are thought to be largely irreversible. of course, overdose. And then more specific to my background and body of work is HIV, STIs, and other bloodborne pathogens. So what we know about meth pretty well, this has been pretty well established, is that about a quarter of folks in our population of interest have ever used meth, even just once. That's been pretty well established. It is possible for meth, of course, to lead to stimulant use disorders and other morbidities. And we know that there is some qualitative work that some individuals can use meth casually, and not everybody will develop a stimulant use disorder right away, which I think often is sort of a narrative that we hear that I think can perpetuate stigma around meth use. And we know that there are interventions like contingency management and some pharmaceutical approaches that are being used and seem to work for folks who are pretty far along with their meth use. But what we don't know so much about is how frequently people are trying meth, and has that changed over time. We want to know how commonly people will and will not develop evidence of stimulant use disorder, and how quickly people will move through this process of using meth for the first time to ongoing use to those more serious outcomes. And then really, I think the most important public health significance of this work is to get a sense of, can we intervene with meth and provide harm reduction and recovery services sooner than when folks develop those pretty serious outcomes. So
Mike, we
this,
do have one clarifying question I just want to
yeah, of
pop in
course.
for. To confirm, does CMTSM means people having sex with people assigned male at birth specifically, regardless of gender?
Yes, it does. I would be happy to talk about the rationale for that definition at the end. It's very long. So we used a mixed methods approach here. We started with a qualitative study designed to understand determinants of initiating meth, so trying it and then going on to use more or not. We wanted to understand how people's individual relationships to meth change over time. And really, the primary motive was to develop a quantitative epidemiologic study instrument with those data. And that would allow us to measure those time patterns, those temporal patterns of trying meth and perhaps developing stimulant use disorders, associated factors or risk factors for those two things, and also looking at trends over time. So for our qualitative work, we used a community-based participatory approach with a gender inclusive inclusion criteria. We worked with Peer Seattle and Seattle's LGBTQ plus center, which are probably familiar to many of you, especially Peter, who works for the center. And we used a phenomenological framework. So we wanted to understand from people's experiences, from their lived experience, how did their relationship to meth change over time? So we essentially just sat down and talked to people for about an hour about everything that happened since the first time they tried meth. We talked to folks who were at least 18, lived in King County or Pierce or Snohomish County, for about an hour at a time, and provided folks with $60 incentives for those interviews. We had 49 people participate. We were purposeful about recruiting people who were not cisgender men to make sure that we could detect any potential differences in the experience of using meth. As you can see, we had about a third of folks were non-binary, a small number of trans men and trans women, and then about 3/5 of folks were cisgender men. For a small study, I think we were pretty pleased with the racial and ethnic diversity for a sample in the Seattle area. And this is current housing status among participants. So at the time of their interview, uh, about 1 in 5 were either unstably housed or considered themselves to be unhoused or homeless. So we had a lot of vulnerable folks participating. And also encouragingly, we had quite a spread of just chronological age, folks who first tried meth in the last year and folks who tried meth as far back as the 1980s. We also had folks initiating meth as young as 14 and as old as 50. So I think we had a really nice, diverse group in terms of relationship to meth, timing of initiating meth. So very, very quickly, the primary themes that we found kind of counter to what I think a lot of my colleagues expected, which would be that people would report trying meth for the first time in sort of like a chemsex setting. Actually, very few people reported that. People talked about trying meth for the first time at work or in other just non-sexual social settings. That was very common. We also found that, again, counter to a lot of the prevailing narrative that certainly I've seen in literature, the process of developing stimulant use disorder or addiction with meth is really nonlinear. So folks will take long breaks, come back to meth for lots of different reasons, and will start and stop over time, kind of irregularly. And this, I think, ties into our final point, which is really that the biggest influencer of the frequency and volume changes in meth use were influenced by life circumstances largely around coping with challenges. And I think this comes up a lot in the quantitative data as well. So moving on to the quantitative study, as an epidemiologist, this is sort of where my brain goes anyway. So we first wanted to put together this questionnaire. So we worked with the qualitative findings of the first study, and then we used the assist and a few other validated measures to get kind of a beginning questionnaire going. Then we talked to 15 individuals who qualified for our first study but could not participate because we were full. And we said, hey, we're doing this other project we'd like for you to participate in. And we asked people to take this survey with us out loud on the phone. And as we went through, I kind of would make notes, this question is perhaps not clear, or the ordering of these should change, or the answer options should change, or we should throw this question out. And we did that over 10 drafts until we had a final questionnaire. So we worked with people to make sure that what we were trying to ask is what we were asking, and that what we were asking made sense, and that it was kind of answerable in a self-administered survey context. I'll also just note that a lot of the items that we included that I do not mention here explicitly were generated through sort of talking with community partners at a couple of events at Peer Seattle. So we got direct input into language and questions that we included that way as well. And once we had this final questionnaire ready to go, we conducted a survey online this past year, actually, across the US. And we had these key kind of questions of interest that I'll kind of address one by one in the results. So we wanted to know what were the correlates of meth initiation typically. So what we have out there very well is what are correlates of ever using meth at all, but that's not necessarily looking at specifically trying meth for the first time. So what's going on in someone's life when they first try meth? We wanted to know among people who initiate meth, what makes folks more likely to develop ongoing use or stimulant use disorder. Are there secular trends in sort of this in the initiating of meth in the population? Among those who do initiate meth, considering these correlates that we find in this first question, what comes first, the correlate, meth initiation, or do they tend to occur around the same time? We wanted to then look at how commonly and how quickly people who try meth develop stimulant use disorder. And then finally, kind of in the same vein as question 4, what comes first? These experiences that we know are associated with stimulant use disorder, the stimulant use disorder itself, or do things tend to co-occur? And to get at these questions, we used some good old standby descriptive stats, regression models, and some time to event analyses with medians and cumulative incidence plotting. So we had about 1,700 people participate from across the whole US. And you can see about 8 and 9 folks were cisgender men. The remainder of people were trans and non-binary, and then we had a small number of folks who have suppressed who identified with other identities or sex assigned at birth. So very diverse population in that respect. I think looking at this nationally, very diverse sample that more or less reflects a lot of demographics, particularly of the West Coast. I'll comment that the biomedical usage in the sample was very high. So over 90% of participants who were living with HIV were currently using ART. That's certainly higher than a random sample of the country. And similarly, among those who were HIV negative, more than half were using PrEP. So again, that's my understanding from most national samples of specifically cis MSM is you see maybe 1 in 5, 1 in 4 using PrEP. So very high biomedical use, both among those with and without HIV. And probably partly because I live in California and work in Washington, the sample was pretty heavily skewed to the West Coast. The West Coast was about doubly overrepresented in the sample, but I will point out that there were participants from all 50 states and Puerto Rico in the sample. So our first analysis, we wanted to compare individuals who have initiated meth to those who have not. And about a quarter of folks had, which again lines up roughly with what we see in the literature. And our first model, we used these sociodemographic variables, these characteristics that were likely defined prior to first meth use experience. And we found that those who were assigned female sex at birth were less likely to have initiated meth. And we also found this sort of linear, if you can kind of imagine this third item here would be 4-year degree as the referent, sort of a linear relationship with um, more education, less probability of having tried meth. And I think that this is really just a proxy for socioeconomic status. Collecting income data is very difficult. Most people don't answer. There's a much higher non-answer. So we chose to proxy that with education, and I think we see that here. Our second model, we wanted to consider experiences that could have co-occurred or occurred after or before first meth use experience. So we used other more experiential and health characteristics in a separate model, and we found that living with HIV, ever having used prescription stimulants, ever having been unhoused or unstably housed, or having exchanged sex were all associated with initiating meth. Then our second question, much the same, but again, just looking at the folks who tried meth, the probability of developing evidence of a stimulant use disorder versus not, which was about 2 to 1 in the sample. There were no sociodemographic characteristics associated with this outcome, but there were very similar characteristics as in the previous analysis. So living with HIV certainly was associated with developing stimulant use disorder. And then these 3 items here were very collinear in the data set. So we decided to make a composite social vulnerability variable. So if a person reported at least one of these 3 experiences, they were indicated as having this social vulnerability, and this produced a prevalence ratio of over 2. So folks with any one of these experiences were in an adjusted model more than twice as likely to have developed a stimulant use disorder. So far, I think none of this is necessarily surprising to see that social vulnerability is associated with increased probability of both trying meth and also with having worse meth-related outcomes. So next, we want to sort of disentangle, well, what comes first, right? So first, we'll look at sort of on the population level in terms of trying meth. The median age at initiation was 26. So this is the overall sample. You can see sort of around the mid-40s, sort of a flattening of meth initiation. When I stratify this same plot by birth cohort or generation, you can see something interesting that sticks out to me right away is that this sort of eldest cohort, which roughly corresponds to the baby boomer cohort, they report initiating meth later, whereas these more recently born cohorts are all kind of all in line with the average. When we disentangle this in terms of chronological time, we see this kind of co-initiation between the baby boomer cohort and the Generation X cohort. And I'll just say briefly, when you remove this pink line, which corresponds to the baby boomer cohort, we see the next three cohorts sort of behaving pretty similarly. So there's something going on around the early 2000s where folks who had not yet tried meth are now trying it, chronologically older and around the same time as younger folks in the same population. And I think, we can speculate about why. It could be a function of selective mortality during the AIDS crisis. So folks who may be initiated younger could have been more vulnerable to acquiring HIV, and not living to take the survey. It also could be secular trends around drug use and norms. It was suggested by a community partner that early 2000s was when buying and selling drugs online became more common. So just an interesting kind of secular trend to see here in the data. So thinking back now to the first couple of analyses, so first we looked at what were those correlates of meth initiation. And we pulled out a few of these here. So those that we had timing data on. So when someone, for example, reported that they were living with HIV, we asked, how old were you when you received your HIV diagnosis? And then we compared that to their age at first time trying meth. And we did that for all three of these variables. So first instance of housing instability or homelessness and first episode of sex exchange. And sort of what we can see here is that for over 60% of folks, the first episode of meth use came before they received their HIV diagnosis. And then we can see kind of the flip, the opposite with housing instability. For about 60%, the first episode of housing instability or homelessness came before meth initiation. And then there's this sort of right in the middle is first episode of sex exchange tends to co-occur for a lot of people, for about 18% of folks within the same year of initiating meth. So you see these three experiences behaving quite differently relative to when meth use begins. So then if we think about the same folks then who initiated meth, how quickly and how often are they developing evidence of a stimulant use disorder? So if we see first this black line here, this is reporting any evidence of a stimulant use disorder as we defined it with our community partners. You saw in a previous slide about 67% of folks report this experience, and that's kind of where this cumulative incidence plot ends up here on the far right. In a median of about 6 years after initiating meth is when we first see that. Certainly a lot of folks, it happens faster, but there is evidence of there being a bit of time between that first meth use and those more serious outcomes. When we look at sort of these three categories of stimulant use disorder or adverse outcomes, we focus first on this pink section here, which is personal, work, or school-related disruptions. That happens on average a little bit faster, about 4 years into after initiating meth, whereas these more medical outcomes, so needing medical care or being hospitalized, on average first starts about 5 years after initiating meth. I think we were encouraged that the majority of people who initiate meth do not require medical care, but I think 20% is still rather staggeringly high. I think these are the folks who kind of represent the most serious complications of use. So now looking to a similar analysis, but focusing on developing stimulant use disorder, I'll just say very briefly, kind of across the board here, these experiences on the whole are preceding the development of stimulant use disorder. I think perhaps the most kind of staggering one to me is that housing instability of all of them is most likely to follow development of stimulant use disorder. I think that we saw this a lot in the qualitative research where folks explained that kind of first trying meth felt very in control like any other drug, and then slowly it kind of became more out of control and escalated. And I think it's unsurprising to see that about 25% of folks who reported ever having experienced housing instability first had that happen after they developed evidence of a stimulant use disorder. So I see kind of this the tricky part of a lot of these analyses is that we have causation could go either way, and I think this is a good example of that. So sort of to wrap up and make the big points here, except for this eldest cohort, which we could think is attributable to one of many or multiple causes, such as selective mortality or changes in drug supply, largely since that cohort, the initiation of meth use in this population appears to be pretty stable given age. We see that male sex assignment at birth is associated with initiating meth. So future gender and specific research that is likely trans-led, ideally, might disentangle this finding a bit further when we think about who can benefit most from interventions. And I think this takeaway that for most people, meth initiation preceded HIV diagnosis, were they living with HIV, that might suggest that for a lot of people, meth precedes HIV acquisition, but our data, we cannot tell that. So we really want to think about in future work, can we have testing history data to get a better sense of for how many folks HIV is something that people cope with and turn to meth after versus something that comes to fore during meth use, as a lot of our participants talked about in the qualitative research. The majority of folks who try meth will, in our sample, eventually did develop evidence of a stimulant use disorder, although it took a couple of years, several years for many of them. So that presents an opportunity to provide services. But we have to figure out what those services are. Social vulnerability appears to predict development of stimulant use disorder. But I think kind of the most important takeaway here is that these are shared risk factors of HIV acquisition in this population. And so when we think about things like ending the HIV epidemic, meth needs to be part of that conversation, especially for this population. And it seems to stand to reason that offering meth-related interventions alongside HIV interventions would be a good use of time and energy. So thank you to my community members, my community partners, including Peter, Population Health Initiative, and the Center for AIDS and STD for supporting this work. I think it's on to you, Peter.
I think it is. Thank you, Mike. I first, I just want to say I've heard you kind of do this before, and I always hear something a little bit more different every time, a little nuance or a little something that kind of surprises me. It just goes to show how complicated and complex this whole issue is. So, and that there isn't an easy answer for any of it. So I appreciate the work you've done. I appreciate the opportunity to have helped out with it. So I am doing a little bit different part of this issue, a little bit more of the one-on-one kind of human side of it. So as I said before, my name is Peter Cleary. I do work at the LGBTQ plus Center in Seattle and have for a couple of years now. Been a part of Project Neon for 12 years now, I think. First as a volunteer and did later in my current role. And you can go on to the next slide. So we're doing a little bit of more of an introduction. I will add to my other part of that. I am an injection drug user. I have been for a long time. And so I do kind of bring a lived experience or living experience to my work. What I'm sharing also with you today, there's some empirical data, there's some well-known, researchable and researched data that might come into my speech a little bit today. A lot of it is anecdotal. I'll be the first to admit that a lot of it is very difficult to prove, or just hasn't had the a great enough researcher yet to come along and do it anyway. And that it is not affiliated with where I work or with what I do directly. I say that not because I plan on going against any of the fundamentals that goes on here at the center, but it is separate from that. Questions are encouraged. Again, this is a really complicated subject that has a lot of human, squishy, undefinable stuff to it. So if there's a question you have, please jot it into the chat or Q&A. Next slide, please. And because I only have 20 minutes, which I forgot to set my timer, but I only have, I'm going to try to keep to this very short and concise list. So why folks use, what is the connection between MSM and meth? What is your goal, meaning
Peter,
those of you out here?
a few people are saying that you're a little bit hard to hear. So if there's
Oh,
any
okay.
chance you can move closer or switch things
Yeah,
up.
I should be in my ears, but I
Okay.
will speak louder. How's that?
Okay. That would be great.
And
Sorry to interrupt you, but I wanted to
no
make sure
worries,
everyone heard
no
what you were
worries.
saying. Thanks so much.
So we will talk a little bit about what the goals of your service providers are, and then how to engage and support folks who are using meth and coming to you. Next slide is fine. So why do people use substances? And this goes beyond meth or, stimulants in general. There are a lot of reasons. And I'm sure if you gave it a little moment, you could probably come up with a few that are even accurate. And even I don't know. I mean, a lot of people that use substances oftentimes say, I don't know. Anyhow, but for at least today and what we're talking about, you can go to the next slide. The reasons are varied. Survival, that's getting a lot of conversation right now out in the world, just because it is, at least on the West Coast, with so much homelessness and unstably housed folk. Survival use is kind of a new and different reason that's significant. There is recreational use. That is also, I think, should probably get talked about more, actually, but because there are people out there that use recreationally or at least non impactful to the rest of their life. There's the self-medicated group, and unfortunately, most of the people that self-medicate are not doctors, and so that's not necessarily a successful group, but it does exist. There's the escape, people that do it to escape, and of course, substance use disorder is also out there. So and that's a pretty wide gamut, and I don't think when you come across somebody that is sitting in your office or your exam room, if you have somebody that is using, I don't think you can necessarily know why right up front. Let's go to the next slide. The thing that connects a large portion of the MSM and meth users is, and I'm going to oversimplify, as Mike just shows us, there's a lot of intersectionality and a lot of things going on there. But for the common sort of connection, it's sex, which is the next slide. There is a component of that for almost all, especially for a lot of the men who have sex with men who are struggling with their use. It is usually somehow tied to either actually or a perception that is tied to their sex life. And that can be, as we know from that mouse that keeps hitting that lever until he starves to death, it's a pretty hard one. It's an additional complication if you're trying to, control or get a handle on your meth use. And that kind of brings me to the next thing on the list, which was, you can go to the next slide, which is, what is your goal? If you are helping someone or are engaged with their care or service in some way, it really, you have to, it seems to me anyway, you have to kind of look at your own goals. And I think for most of us on the surface, that's pretty straightforward. Next slide. It is quite simply that you want to help, right? You want this person's health to be better, their service, you want to provide them with services, get them housed, whatever it may be. It is one of, where you're trying to be helpful. Here's the interesting thing with that. It is what you think is helpful and what they think is helpful are oftentimes not exactly in the same priority. And I think that that's where a lot of challenges can come from serving this population. Yeah. And I think this population, on the flip side, I think this population comes into the transaction expecting to not be helped. They're expecting to get, a different reaction for the service provider than what's actually being given them. And so it automatically sets up this conflict before anything even happens. So it is a challenge to say the least. You can go to the next slide. So we've kind of covered all of that, and I did it very quickly, very briefly, because I think that for the most part, given the complexity of the issue, most of that is fairly straightforward, and I'm sure that most of the folks listening to this right now have some experience along those lines. Nothing big and telling there. I think I got asked to be here for a lot of reasons, is to help bridge that gap between the provider that wants to help and the community member that is already being sort of combative or hard to receive that. So anyhow, with that in mind, how do you engage these people? You can go to the next slide. There's a whole lot of ways, and I can't stress enough that each case and each person is going to be different. And even that person from one visit to the next visit is going to be different. And I think that's one of the things that makes this so challenging. It's really easy to just say, hey, if somebody's homeless, get them housing. That's great, but that's not how it really works in the real world, especially if you have the complication of somebody who is using substances, particularly meth. Yeah. So next slide. One of the first things you can do, I think, to help engage people that use meth is to normalize harm reduction. If harm reduction is going to keep them in a place where that they're able to accept the help offering, first of all, it's going to give them at least a little bit of healthier current life, whatever is happening in the moment. And harm reduction is so tied with drug use that it sort of has all of the stigma that goes along with that drug use, right? So by having it under the counter, or I mean, even if harm reduction is something that you or your organization supports, it needs to not be under the counter or behind or the secret room down the hall or any of that stuff. It really needs to be upfront. I think it would be great to just have a bowl of with kits in it for doing safer injections at the front desk, kind of thing. It does a lot for you and your organization. One, it starts a conversation, which I think is great, but it also just takes some of the, I'm a bad person and I need to go get my special stuff it just that gets all tied up and keeps it all secret. And as anybody knows that's done any social work at all and tried to fix the problems of the world, if it is a secret, it is damaging, period. So normalizing harm reduction and being willing to talk about it and have it be a part of the conversation with all of your clients or customers or patients, depending on your point of view, I think is very important. It also ties into the next thing, which I think is equally important, in that is you have to build trust. You have to have a connection with this person that you are trying to be of service to. Even though, like I said, I think that they know that is, they come at this expecting a fight, you have to build that trust. Nobody is going to really open up or be willing to make a change unless they feel like they can be safe enough to share. And it's just that simple. It's very hard to do any good work with anybody for any reason without some trust behind it. And here's the one I think that trips up a lot of people, and that is self-determination. You have to encourage and mean and support self-determination. Most people, in my experience that I have met over the years in harm reduction, they want very specific and positive changes in their life. Very seldom do you ever meet somebody that really just doesn't care. It's an anomaly. Most people have very clear ideas and want to go forward and get better in their life, whatever that looks like to them. And that's the key. It's whatever it looks like to them. What you think is most important in a person's life when you're trying to provide services is not necessarily what they think is important. And the phrase meeting them where they're at, I think that's great. And I think that that is something that we should all do. But meeting them there doesn't mean then to immediately scooping them up and taking them somewhere else. Meeting them there and helping them means you're there with them for a minute, right? They may not think housing is a big deal. I know when I was, and I neglected to mention this earlier, but I was unhoused or unstably housed or homeless for a little over a decade way back. And housing was not my issue. I was one of the fortunate ones that had some other resources that made housing or lack thereof pretty bearable. But if somebody just came in and said, "Hey, we got to get you housed," it's not what I needed right at that particular moment. In any case, so I think supporting their self-determination is the most important thing. It's very hard to do because as we are looking at these people or meeting these people or chatting with these people, we have usually, most of us have very strong opinions about where they should be or where they could be. And that's not important. It just really isn't. Where you are in your life is none of my business in one way of saying it. You need to really sit down and have a long conversation. And I realize if you are in medical and some other areas of this, it is very hard to get that long conversation, but you really need to figure out a way to communicate with the person and find out what is most challenging for them today and in the short-term, future, and work on that first. If in fact you truly want to help, and if in fact you're trying to build trust and that sort of thing. And maybe there's nothing you can do for them according to their goals. That's great. Send them, find another place for them to be. But anyhow, I can't speak highly, or I can't stress this enough that self-determination is key. You're going to get a lot more buy-in. You are going to have people take that first step, and when they take that first step and there's a little bit of success, it's a lot easier for them to pick up the pace and take a lot more steps. So like I said, I can't stress that enough. Here's the other part that's oftentimes very difficult for us. We also have to accept that that success may not come while we're around, right? And that you may not get closure on this particular client, or you may not get much traction on this particular client. There's a whole lot of things that we might not get out of that, and it makes our job very difficult. I completely understand and respect that, but we do have to be prepared for that. I do know also, though, that when I've talked to people that have gotten a lot farther down that road and are a little bit more successful than they were, say, 15 years ago, they oftentimes speak about a person who's no longer around, doesn't work there anymore, whatever the reason. But they oftentimes speak of that initial one or two people that took the time to hear them. And it is even later, much later in their journey, that's what they still kind of grasp onto. So that can be encouraging, and I do try to share that with people because I don't think we often hear we don't hear often enough that we have done good in people's lives. Anyhow, a little divergent there. There was something else that was not on my notes that I knew I should have jotted down. It'll come to me in a moment. Anyhow, and where am I on time, Allison? We are
Maybe
just
wrap it
about
up pretty soon, but
Yep. And that is, it is, like I said, it was a little bit quick, a little bit brief. It is not as much. Um, yeah, I will just wrap it up there. I think I think yeah, I will take questions at this point, or Mike and I both will, I think, take questions. Um, there's my contact information. If anybody has any questions about Neon or about anything I've said, I am more than happy to chat about it. Um, yeah. So.
Thank you both so, so much. I don't see any current questions in the chat or Q&A, but do you two have questions for each other to sort of kick us off?
Oh,
And please enter any questions in the chat or Q&A.
I do have a question for Mike. Is there what of the current research that's lacking, because there is a lot of holes in our research on this, where would you like to, based on what you've done in the past already, what would be the sort of ideal study, the perfect thing that you would like to set up, or maybe you are setting up? I don't know.
Yeah. Well, if the NIH were a hospitable place for me to acquire research funding, which it's not at this point,
Right.
I would I would like to develop approaches to interventions for meth that are uh, affirming, that are harm reductive in approach, and that are designed to reach people before they end up with one or many of the many kind of really severe health conditions that meth can cause or worsen. I mentioned this really briefly. There is a lot of work that's been done around contingency management and using other pharmaceutical medications to kind of, I mean, it's biologically very different than something like buprenorphine for opioids, but I think the idea of giving people medications to kind of replace or help them diminish use is one approach. But those two examples, again, reach people kind of when they're furthest along. So
Right.
I think if we can minimize harm as early as possible and think about how different experiences inform people's substance use, not just meth, but other drugs too. And we can co-locate those services with other population-specific services like HIV and STI prevention, which I think, as a gay man, I feel like I'm inundated with. Obviously, I work in this field, but we see it everywhere.
Right.
I think we need to see normalization of meth use in the community. Not to say that we should promote it, but that, like you said, when things are a secret, they can become really harmful. So I've been really pleased to hear that on social media apps like Grindr and Scruff and the like, you can indicate if you're using PrEP or if you're not, or if you're on ARTs. And I think it would be great to see more opportunities for people to get in touch for support before they end up in a bad way, as we've discussed.
Yeah.
But
Yeah.
yeah,
I
maybe
totally
in
agree.
4.5 years, I can start that work. Not right now,
Yeah.
though.
That you bring up a couple of good points in there. One, the next 4.5 years, I think we're headed for some, really dark and scary times for a lot of people in service providing, and we need to sort of bolster our contingency plans. Um, but yeah, I think you mentioned contingency management. That is about the only sort of process that has shown a lot of good results and good work behind meth substance use as it relates to meth. And I think probably the only reason we haven't found a methadone or a Suboxone is because I think it is surprising to people how many people actually die from meth use only. When you hear the word overdose, everybody goes to opioids instantly. And while that is certainly an issue and has become even more of an issue, people do die of meth, overdose, meth poisoning, right? And I think I think that is finally coming to light a lot more. especially I know here in King County, there was that year back there, I think 2019, whatever it was, that meth use only surpassed deaths, past opioid deaths. So it is a thing, and I think people are paying a little bit more attention to that. So I appreciate that. Yeah, because we've got to figure out something.
And I do have
And
a question for Mike in the chat. Did you see it, Mike? Or
from Alan,
yeah. What are some
what are
future directions your work has led to?
yeah, so this work is still all in the peer review process, so nothing yet. But I would like to see I think what I call for is a couple of things, and I'm going to address a question that came up earlier in this answer. I think that the population that I talk about, so we defined our population based on risk of HIV acquisition. So we know that when it comes to HIV transmission, sexual anatomy is what really is important. So having sex with a partner with a penis is a greater opportunity for HIV transmission than a partner with a vagina, which is why we chose to define our population the way that we did. And to that point, I would like to see more work in this area that is both gender affirming, trans inclusive, but also really specific. I know what I encounter a lot is I hear things like trans people are disproportionately impacted by HIV. That's actually really not accurate. Trans women and trans feminine people are indeed disproportionately impacted by HIV. So I think we owe it to our populations to be really specific. I think something I work on in my own personal and professional life is kind of balancing between advocate and scientist. And to see in this work, and again, I can't not talk about HIV prevention and STI prevention work too, gender inclusive and gender specific research. And then I think the other piece to Alan's question, the majority of what we learned in this research wouldn't have been possible if we didn't have the direct input of people with lived experience in the development, conducting, implementation, and interpretation of the research. So people like Peter were part of this work. And nobody on my research team from the UW side certainly disclosed having lived experience with meth. So, and I don't either. So I'm not qualified to talk about any of this from a lived experience perspective. But the value of having that really made this work what it was. There were so many places I can tell you where we could have made a different decision about a measurement or about an analysis that was really meaningfully changed by having direct input from the community. And I think really just from like a business perspective, like if you had a company, you wouldn't make a product without asking people who could use it what they think about it. You know, if we want to make public health interventions that work and I think we agree like substance use is an ongoing kind of getting worse problem in the US that we don't really have a lot of good solutions for. So my hope is to kind of move that needle toward really actively including people who can speak to the issue firsthand.
And if I may add to that, back it up a little bit about the trans community as a whole. And that research would be great if it were trans-led. I know you mentioned that too, but even amongst organizations that have done this work for a long time. Like I said, Neon's been around since '93, but for the longest time, for the first probably 20 years of that, we were listed as being of service to gay, bi, and trans men. And fortunately, we dropped the men for a while. It was just trans folk. But even still, trans men, as you just pointed out, have a lot less to do because we were also HIV prevention back then, and it had a lot HIV. Trans men were just not our overlap. So even here we are, supposedly a professional organization doing the work out in the field. Even we got it wrong way back in '93. So yeah, so much of this. We have neglected the trans community for so long in so many areas, and it would be amazing if we got them to do, supported them in doing their own work so that they could find their own answers. But yeah.
What I'm hearing a lot from both of you is that it's really important to involve people with lived experience, and it's really important to listen to people about what their goals are. That we shouldn't prescribe people what we think they should do. I really love hearing that in an academic setting and then in a really, social work peer-based setting. I think that's really valuable, and that's what's really coming through for me at least. So I do have to wrap us up. If you could move to the last slide. Um, I made Mike and Peter keep things really short, and I appreciate that they did that because I loved this dialogue and having both of them here. But I know that they both have so much knowledge, I could have had them each do their own webinar. So I will be posting these slides and the webinar and sending out an email to everyone who attended and those who couldn't attend that will include slides, webinar, and a link to our symposium. I just want to say thank you both so much for this. This was really fascinating. I loved hearing about things at such different levels too, and really breaking down a lot of misconceptions people might have about working with the populations that you work with, and really unpacking the complexity of it. So for me, that was so valuable. So really appreciate you, and thanks everyone for attending. Oh, good. Someone says the resources will be helpful to have. So, yeah, these were great. And I like how, even without trying, you sort of synchronized your slides so they both looked very nice and geometric. So, no, there's no CEUs available, unfortunately. Um, Not for this. For some of the SOAR webinars our team does, there are, but not for this one. But thank you so much and really appreciate everyone attending. And yeah, everyone have a great spring day. Bye.
Thank you.
Thank you.
I'm trying to turn off the recording.
You're